body, right? But on the newborn side, you're gonna have air-filled, low pressure that encourages blood flow through the lungs, right? So we're going through the lungs for gas exchange. So this is gonna cause an increased oxygen content of the blood in the lungs, contributing to the closing of the ductus arteriosus. So we know in the fetus, the site of the gas exchange is placenta, but now in the newborn, it's going to be the lungs, right? For our circulation through the heart, we're gonna have pressure in the right atrium is greater than in the left, and that encourages the blood flow through the foramen ovale, okay? That's what's happening in the fetus. On the newborn side, that pressure in the left atrium is gonna be higher, causing the foramen ovale to close. So it's all about the pressure gradients here, how those shunts are closing.
And then does the tissue heal? Well, I guess it does because it's wet and tissue.
Mm-hmm.
Okay.
And actually the ductus arteriosus turns into a ligament.
Okay.
Hey, this is where your ligament plays into play,
No.
right? We got a ligament, right?
No.
Hepatic portal circulation, so that ductus venosus bypasses the maternal liver, performs filtering function, but in the newborn, the ductus venosus closes, becomes a ligament, and the hepatic portal circulation begins. Okay? So the fetus, the body temperature is regulated by mom, right? And just the whole fetal environment, right? The newborn is born, the body temperature is maintained through a flexed posture and brown fat in the baby.
Brown fat?
Brown fat.
As opposed to
White fat. I don't know.
I don't
Yellow fat. Yellow fat. So, again, those lungs fill with air, that pressure changes, the ductus arteriosus closes in response to that increased oxygen. The left atrium pressure increases, causing foramen ovale to close, hepatic portal circulation begins, and body temperature regulation begins. This is another nice little chart that kind of summarizes what's happening with the fetal to neonatal circulation and explaining the pressure changes again. So our cardiovascular system, we're changing from that fetal to newborn circulation. The change of the placental gas exchange over to pulmonary gas exchange. So the newborn is now controlling everything that mom was controlling first. So physical forces lead to an increased release of catecholamines, critical for changes involved in the transition to extrauterine life. We're going to see all those changes in the fetal structure, that those foramen ovale, ductus arteriosus, ductus venosus, and umbilical arteries and veins are no longer needed.
And the catecholamines are epi and norepi?
Yeah.
Okay.
So as soon as that cord is clamped and breathing initiates, circulatory transition begins. Just automatically happens. It's kind of crazy if you think about it, right? So there's that decrease in pulmonary vascular resistance with the first breath. So that change in pressure. So again, that oxygenated blood starts to flow and pressure changes and prompts the shunt closures. Newborn heart rate is the same as the expected fetal heart rate, so 110 to 160. Blood volume can be dependent on cord clamping. So if we do an early cord clamp, there's going to be less blood volume in the baby. But if we do delayed cord clamping, which is our goal of 60 seconds or more, that baby's going to have a higher volume. So typically about 80 to 100 milliliters per kilogram of body weight is blood volume. But that can be, again, dependent or variable 25 to 40% depending on the time that cord was clamped. For blood components, the red blood cells in a newborn typically have a lifespan of 80 to 100 days. Again, just a reminder of the circulation, so you've got a comparison of that fetal heart to the newborn heart. Right, so initially right at birth, we do an APGAR score. The APGAR score was introduced in 1952 by Dr. Virginia APGAR. She was an anesthesiologist at Columbia University. And this is a worldwide tool that uses to evaluate the baby's ability to adapt to extrauterine life. So how well is that baby adapting? APGARs are scored from 0 to 2, and we score it off of APGAR, which is appearance, pulse, grimace, activity, and respirations. So APGAR. We covered this pretty well in OCCP, so I'm not going to go too much further in depth, but just know 0 to 3 is considered severe distress. 4 to 7 would be further observation. I left out the 7, sorry. 8 to 10 is normal, right? Most babies don't ever get a 10 though, because most babies are going to have some form of acrocyanosis.
What was the second A again?
The APGAR,
Yeah, the second.
appearance is the first A, and activity is the
Activity.
second A. Yeah. Don't delay resuscitation to assess the APGAR. So those of you who've been in your labor and delivery rotation and have seen a baby being born, I'm sure you probably haven't really seen a nurse pull out the stethoscope at 1 minute to get the heart rate, right?
Mm-mm.
Because I can assume if that baby's crying and is fairly pink and has good tone, that heart rate's going to be greater than 100, right? So if a baby is floppy and blue and not crying, I'm going to take that baby over to the warmer. I'm going to be drying and stimulating, and somebody else is going to be listening to the heart rate, because that heart rate determines what kind of intervention I'm going to be doing next anyways. So on a baby who comes out limp, not crying, if their heart rate's less than 100, I'm pretty much giving rescue breaths right then and there. If the heart rate is less than 60, I'm starting CPR. So I don't wait until the baby doesn't have a heartbeat to start CPR or to start chest compressions. I'm starting at 60. So that's where that don't delay resuscitation to assess the APGARs. That's something you can kind of go back and assign. So the lungs. Before the newborn lungs can maintain respiratory function, certain events must occur, right? So we've got to initiate the respiratory movement. Those lungs have to expand. There has to be an establishment of residual volume or oxygen during that expiration. We're going to have increased pulmonary blood flow and redistribution of cardiac output.
That's interesting. How do you get the word just completely left my brain? The reserve. If you start with 0 and then you take your first breath, you think you would exhale the same.
Yeah.
So how does the reserve get in there?
It just starts to build up.
Okay.
Yeah, with every breath that they're taking, they are trying to build up that reserve. So we've got that transition from intrauterine to extrauterine, so that those fluid-filled lungs are now air-filled. That first breath actually inflates those lungs, increasing our pulmonary blood flow. We have something called surfactant, and surfactant is a surface tension reducing lipoprotein that prevents alveolar collapse. So surfactant helps in fetal lungs to expand the alveoli. It prevents that alveolar collapse, ensuring effective gas exchange. So a lot of preterm babies aren't born with the surfactant that they need. So surfactant is actually something that we will give to preterm babies. What else is gonna help expand those alveoli in a baby? Crying, right. So also the importance of drying and stimulating, getting them to cry to expand those lungs to help with that gas exchange. Respirations in a baby are 30 to 60 breaths per minute. They're going to be irregular. They're going to be shallow. They should be unlabored. You should not see any retractions or nasal flaring. And babies may have short periods of apnea, and that's all very normal. Okay? That's why we're going to listen to respirations or observe respirations for a full minute because of the irregularity in them. We're going to have something called transient tachypnea of the newborn. So this is going to be just an increase in respirations during that transition phase of the baby. So we may need to provide them with oxygen, or we might need to provide them with positive pressure to expand the alveoli. We're going to ensure that they stay warm during this period because most likely the baby will be over at the warmer where we're working on the baby. Observe respiratory status frequently and allow time for pulmonary capillaries and the lymphatics to remove the remaining fluid. We call this a lot of times just transition. The baby's having a hard time transitioning to that extra uterine life. And one of the best places for baby to transition is skin to skin. So if I have a baby that's not like critical or really severe, but maybe is tachypnic to the point of like 60s and maybe a little bit of nasal flaring, but not really in like full distress, I'll take the baby over to mom and do skin to skin, keeping a close eye monitoring the baby, and a lot of times that'll help settle that tachypnea and help that baby transition a little bit better.
So that's only if there's a tachypnic?
What do you mean?
Never mind. No.
Okay. Are you sure?
Yeah.
Okay. So body temperature regulation. So babies lose heat. Okay? And it can lead to compensatory mechanisms. So babies don't shiver, right? They don't have that shivering reflex yet. So in return, they're going to start breathing faster, is what's going to happen. So a lot of times in a cold baby, you're going to see a higher respiratory rate.
They can't go to Halloween as the pirates.
They can't what?
They can't go to Halloween as pirates.
No.
Because they can't shiver their timbers.
Bro.
Yes, okay. So this can lead to decreased body temperature. You might see them lethargic or weak or hypotonic. Increased oxygen requirements here, so they may have a low pulse ox if you put them on the pulse ox. You're going to have decreased surfactant production, respiratory distress, hypoglycemia, metabolic acidosis, and you could see jaundice. So what causes the baby to lose heat? Because this is a big issue with babies. Babies have thin skin, and their blood vessels are really close to the surface. They lack that shivering ability, so they have limited stores of metabolic substrates, so that glucose, glycogen, and fat. Limited use of voluntary muscle activity, so it's not like they can, oh, I'm cold, so I'm gonna try to warm myself up, right? They can't do that. They have a large body surface area relative to their body weight. Really, the second time around trying to say all of this with only like a 25-minute break in between, it gets to you a little bit. So lack of subcutaneous fat, babies don't have a lot of fat, right?
Gotta advocate for a longer lunch break for ourselves.
I do. Yeah, you guys too.
Mm-hmm.
No ability to adjust their clothing. I can wrap myself up if I'm cold. Baby can't do that, right? And infants can't communicate whether or not they're cold or hot. I think back to, I had just had Jack, so I'm a new mom, and I took him to Target, one of our first ventures out, by ourselves. And it was like a super, super cold day, so I put him in this cute little bunting suit. And we're in Target, and he's fussing, getting really upset. I'm like, what's wrong with this kid? So I take him into the bathroom thinking I needed to change his diaper. Well, no, he was soaked underneath this bunting suit because I had wrapped him up so much because it was so cold outside. And I was like, he's gonna be so warm and so cozy. Yeah, he was warm, just sweating. So once I got him out of his bunting suit, he was much happier. So heat loss in newborns. How do babies
Bless you.
lose heat? The same way anything else does. So think back to chemistry, right? I guess that chemistry is when you guys would have learned about this. We've got conduction, convection, evaporation, and radiation. So conduction is when the newborn's placed naked on a cooler surface, such as a table or a scale or a cold bed, and that heat goes into that surface. Convection is when the newborn is exposed to cooler air, a draft, or like the AC blowing out of the vents in the rooms. I always think about that in the hospital rooms when the parents turn on the AC and they have the baby over by the bed or by the little couch and the air conditioning is blowing all over the baby. But they can lose their heat to the surrounding air or liquid. Evaporation, the infant often loses heat when the amniotic fluid is on their skin and it starts to evaporate. So another reason why drying and stimulating is important. And then we have radiation, when the newborn is near cool objects, such as walls, tables, cabinets, without actually being in contact with them. And this is the primary cause of heat loss after birth, is the radiation. So management of thermoregulation. What are we gonna do for a baby to help
Swaddle.
regulate? Swaddle, skin to skin,
Beanie.
hat, pre-warm the blankets on the warmer, right?
Toque if you're in Canada.
A what?
A toque, that's what they call a.
Oh, the hats.
Mhm.
Okay. Keeping the infant transformer or the isolette warmed at all times, right? Because if I have to move that baby to the NICU or somewhere, I want it going into a warm environment. Let's see. Deferring bathing until the newborn is medically stable and using a radiant heat source while bathing. Is also an intervention. Typically, we're gonna delay that bath for about 24 hours. We will bathe the baby sooner than that if the parents request. Promote early breastfeeding can also help regulate temperature. So, our hepatic system starts to work, right? And we're going to start producing our own glucose. We're going to metabolize any drugs. And that liver's going to help with bilirubin excretion. And that bilirubin is what causes jaundice in babies. What's jaundice?
Yellowing of the skin.
Yellowing of the skin, right? So our hepatic function in newborn is immature liver function and decreased hepatic blood flow. So we're gonna start to produce the glucose and we're going to start regulating our own glucose level. We have a limited ability to conjugate and excrete bilirubin, and that's what's leading to our jaundice. We're also deficient in our clotting factors, and the liver will take over to start producing those within the first month. So we talked about the manifestations of jaundice. You're gonna have that yellowing skin, yellowing eyes, and typically you're gonna see it after the first 24 hours of life. So hyperbilirubinemia, sorry.
I'm sure you'll cover it, but I always get confused with jaundice in newborns. Is it like a, oh crap, this is a bad urgent thing, or it's like it can be an expected abnormal sometimes, like it's not that
Depends
bad.
on the severity of
Yeah.
the jaundice, what your bilirubin levels are.
Okay.
If you have really high bilirubin levels, then yeah, it can be an oh crap, let's get you under lights. But sometimes it could be as simple as baby's a little bit yellow, bilirubin level is slightly elevated but not bad. Put that baby by an open window and let them get some sunlight. So hyperbilirubinemia begins after 24 hours of age, can be from breast or formula feeding. They might need phototherapy, and we want to monitor their hydration status, stools, and skin color. So bilirubin conjugation is the process of turning bilirubin, so that breakdown of our red blood cells, from a fat-soluble to a water-soluble pigment. And it's excreted in our feces, our urine, and our bile. So the source for newborns is that red blood cell breakdown. And elevated levels result in jaundice, so it can be an overproduction, it can be a decreased bilirubin conjugation, or an impaired excretion of those broken down red blood cells.
For those stools, would it still be that pale, like the clay?
It's gonna be
like
Yellow and
newborns?
seedy.
But that's like the expected, right? But for jaundice, I'm sorry, would their, bowel movements be clay colored and like pale for jaundice? Cause it said to watch the stools. For jaundice, would they, like that regular,
So a lot of times they're just gonna be that yellow and seedy because they have that increase in bilirubin and they're trying to get it out.
okay, so it's not like an adult, like.
Right.
it would be- Okay, gotcha.
Right. Yeah, they're trying to excrete all of it out. So physiological jaundice appears after 24 hours and it peaks at 72 hours of life. So a lot of times newborns are out of the hospital by the time they're diagnosed with jaundice, right? Because they're gonna go to the hospital like go to the pediatrician 24 to 48 hours after discharge, and that's when they're gonna get diagnosed.
I have a question.
Yeah.
So I was like, when I was reading the book and even in the PowerPoint, I'm still kind of having trouble understanding, like, so their bodies produce too much indirect bilirubin. They can't break it down, and that's where it comes from. Just the jaundice, and that's the regular kind that like most kids get.
Or they're having some issue in excreting it.
But then, like, so they can't break down fat to like pass it, which is why they have fatty stools. Is that why like they're having a problem breaking it down, or is it just because the liver's too mature?
Yeah, the liver being immature.
Okay.
Grow up.
So it's very common, especially in preterm newborns or with delayed meconium stool passages, again, because of that liver being immature. Resolution is slower when a baby is breastfed. You think about formula, all the additives, it's iron fortified, and I mean, mom's breast milk has all that kind of stuff too, but it's a higher number in formula fed babies. Pathological jaundice appears within 24 hours of birth, requires intervention. Some associated causes include a blood type incompatibility, systemic acidosis, cephalohematoma, which is a blood collection underneath the skin on the skull. Can lead to acute bilirubin encephalopathy and chronic bilirubin encephalopathy. So our GI system. Our GI system is going to start developing our mucosal barrier to prevent penetration of harmful substances. The psychological or physiological capacity of a newborn's stomach is considerably less than our anatomic capacity. So really when a newborn is born, their stomach is maybe the size of a marble, and they still can't even hold all of that, right? Because we worry about it coming back up. Because their cardiac sphincter and the nervous control of the stomach are immature, which can lead to that reflux that a baby will experience. So typically, if a baby is formula fed, how much will they eat in their first couple of feedings?
Up to 10 ml.
Yeah, like 10 to 20 mLs,
Oh,
no
10
more
to
than
20.
20 mLs for the first couple of feeds, right? And they're gonna eat that about every 2 to 4 hours, depending. And if they eat more than that, most likely it's coming back up because of that sphincter being immature. And sometimes it can take up to 3 months even for that sphincter to really fully develop. To gain weight, the newborn requires an intake of 108 calories per kilogram a day from birth to 6 months of age. Doesn't mean that's like all the baby requires. Baby might require more, but to gain weight, they need at least 108.
Per kilogram, dang.
Stools. So initially, that first 1 to 3 days, you're gonna see these meconium stools. Dark, tarry stools. Then we're gonna see transitional stools. The stools are gonna be a little bit more mud-like, if you will. Day 5, we're gonna see yellow stools. These are gonna be those yellow, seedy stools. So all of that bilirubin starting to come out, right? And then, depending on whether you're breastfeeding or formula feeding, your stool is going to be a little bit different. So breastfed newborns, yellow, gold, loose, stringy to pasty, and kind of sour smelling. These are the babies, breastfed babies are the ones who are gonna have those blowouts all the way up to their neck, right? Like all up their back, all down their legs. Formula fed, typically yellow to yellow-green, loose, pasty, maybe a little bit more formed, and an unpleasant odor. Formula-fed babies really, and depending on the type of formula, their poops smell awful. Terrible, terrible, terrible. Okay. So remember we talked about our postpartum adaptation and GDM with gestational diabetes, right? Mom is producing an increased amount of glucose to provide for her and the baby. So we're taking away all that glucose from the baby. So babies are at risk of hypoglycemia. So this is a plasma glucose concentrate less than 45 in the first 72 hours of life. So some babies we know are at high risk for hypoglycemia. What babies are at high risk for hypoglycemia? GDM. What did you say, GBD or something? I knew what you were saying. GDM. What else? Macrosomic babies, so babies that are large in weight, so over 4,000 grams. Who else?
AMA.
Yeah, well, any diabetic. We said GDM, but any diabetic moms.
So she's taking,
Yeah.
AMA.
Maybe. Preterm. Okay. How about cold babies? Yeah. Babies with a low temperature are at risk for hypoglycemia. So to treat hypoglycemia, we need to give rapid active glucose. We want to feed the baby. Really, formula is probably the best way to go because we know that the baby is actually taking in. Whereas if we put the baby on the breast, we're not sure on the status of milk, the mom's milk production, right? And we want to monitor symptoms. So we had a baby in clinicals this past week who axillary temp at the end of assessment was like 97.5. So we put that baby skin to skin, double blanket, put a hat. They went back in 30 minutes later to do another temp. Couldn't get a temp axillary, so they ended up doing a rectal temp. That baby ended up being like 95 something. So So we automatically checked a blood sugar, and the baby's blood sugar was 37, then 38. So that baby got Sweet Cheeks or the glucose gel, and monitored in the nursery under the radiant warmer. We got the temperature up, we formula fed, and the sugar got up to like 68 or something like that. And then that baby kind of regulated and stabilized after that. So renal system adaptions, rapid increase in renal blood flow, and glomerular filtration after birth. So these babies will have a high urine output initially, contributing to a weight loss. Kidney function stabilizes within the first week, but a 6 to 8 voids per day is really considered normal. Immune system, babies are born with very limited immune system. They just have an acquired immunity from their moms, right? And then they can gain additional immunity in what forms? How else can they gain additional immunity?
Vaccines.
Vaccines. What else?
Did you already say breast milk?
Nope. Breast milk. That's the other one, breastfeeding. So by breastfeeding, we're providing a defense against viruses and bacteria for our babies and reducing the risk of infant health issues. That breast milk contains maternal antibodies, immunoglobulins, and white blood cells. Skin. So our skin is a protective barrier between our body and the environment. It helps us limit the loss of water, prevents absorption of harmful agents, protects and thermoregulates. Neonatal skin properties include a thick epidermis. Initially, skin is kind of deep red or purple, maybe with some acrocyanosis, right? And then we're going to transition to an ethnic appropriate color. On our skin, we might notice some vernix. What is vernix?
The
That protective waxy coating over the skin. It's composed of water and lipids and proteins, and it shields the skin while it's in the amniotic fluid, right? So that's kind of why when a baby comes out, it's not looking like a pring. Okay.
and you don't like necessarily wash it off because it helps with thermal regulation, right?
Correct. So it's recommended that vernix stay on the skin for the first 6 hours of life. You might see some lanugo, which is going to be fine, soft hair present on various body parts. Again, that helps with that thermoregulation. And it's typically shed within the first few weeks. So on a baby who's kind of early term or a late preterm, you're going to see a lot more lanugo than you would on a baby who's 42 weeks, because that baby has already started to shed that lanugo. Some typical post-birth skin changes you might find. Dryness and flaking and peeling skin, all normal. The skin may redden during crying episodes. Neurological system adaptions, really we're going to pay attention to these reflexes. That's going to be an indication of neurological development. There is a handout on Blackboard that reviews your reflexes for your assessment. Make sure you're familiar with that. Babies are also starting to develop a sense of hearing, smell, taste, touch, and vision. Our neurological system is starting to take control of our respiratory, our circulation, and our thermal regulation as well. So skeletal. Newborns are born with approximately 270 bones.
Huh?
And then once you become an adult, you have anywhere between 206 and 213, right? Because a lot of bones are gonna fuse together and then form as one. So the major bone that's going to fuse is what?
The skull.
The skull, right. So our skull is made up of 1 occipital, 2 parietal, and 2 frontal skeletal bones. So as our brain grows, our skull can expand to get bigger for that brain, right? So we have sutures, and the sutures are those areas that oh my gosh, I lost my train of thought. It's been a day. It's the connective tissue allowing the skull molding and brain growth, right? So the sutures are those opening areas in between the bones.
So some people are walking around adults with 213 bones. What? Which ones? What extra ones do they get?
I'm not
I don't
sure.
understand.
I'm not sure what doesn't fuse. And then we have our fontanelles, and our fontanelles are our gap in our skull bones, the anterior and posterior fontanelles.
So before the growth plates, that's considered 2 bones? Like in the long bones? You know what I mean?
Yeah,
So that's considered 2 bones, and then
Yeah.
when the growth plates seal.
Yes.
Okay.
yeah, exactly. Ooh. What did I just do on my end? Hold on.
Uh-oh.
Okay, we're back. What time is it?
154.
Let's take a 5-minute break and then we'll start back up.
Have you seen the AI videos of the babies like when they're born they run? Yoga, so what? Or like the animals where they like have the AI scanner. Really? Those pet bunnies jumping on the trampoline. That's real. What? No, that's real.
Those are not real.
And then there was one with a cat throwing missiles like
Okay, that's of course not real.
I don't know, it looked a little real to me. Sometimes I can't tell that you have to read the comments. And I'm like, wow, am I getting old?
And I don't think
Start calling you grandma.
Hey, Granny?
Mm-hmm.
Call me mama. Oh wait. What? I mean,
I was just
Moo-Moo?
thinking of what's that show
What?
where she's like, I'm a mom.
Oh, Mama Zita. Yeah. That's from Love Island.
Yeah. Mama Zita. Oh man.
they're not much more loyal, but. Yeah. They can work in the stitches. I work with those men. They love that. They love their job. Yeah. That's because they can see there after. Girl, wait, I'm kissing there.
Oh, I know that one. I know
I don't know, I feel like I didn't feel like
I've like been with them for hours now, just like.
Or that Friday. That Friday. Just be like, yeah, we're going to leave it there. Exactly, I'm not starting. I'll find it tomorrow. Well, we have to use it. There he is.
Yeah.
She's saying like circle star highlight. You asked for it. Where she tells you exactly what is on the so that you can watch and for each topic. Because mine's up.
I know they have like 1 day and a half and stuff.
But yeah, you don't have
I know, I have to go to the state. Here today and tomorrow.
He always brings it like just when treats all the time. He brings like fucking fried toast.
I don't know what happened with the market.
I never learned to read.
Early birthday.
Well, exactly.
It was a family father. I mean, some motivation.
I got that when I work. I got that.
When did they tell me?
Everybody keeps telling me to stop and just live. The same color.
Yeah.
Kind of the same.
Is it a B? 11 to 7 I have.
So that was dresses that I was telling you guys.
That's an only like 11 to 7. Like I don't know if you ever had like a part-time job before working at birthday. Those are the worst. Like
This type of dress,
Yeah, it's really.
so cute.
You know what got me? I just have the one flavor though I never change.
Like fun little dress.
The NICU and she was just chatting with her coworkers.
but there's a higher. She's also but they I mean, no.
All right, you guys ready? All right, bring it back in, guys. Okay, so we're gonna talk about nursing management for the newborn. So we've talked about some changes, the fetal to newborn changes, but now we're gonna talk about really caring for the newborn, the normal newborn on postpartum. So we're gonna do some different screenings. One of those screenings is a PKU. This is a congenital genetic test that we do. And then hearing is another one we do. We also do CCHD, which is a congenital heart defect test. So PKU is required in most states. Really, I think it's mandated in every state. Commonly known as the PKU test. This is a heel stick test. So the nurse is going to apply a heel warmer, stick the heel, let the drops of blood form, and then we're actually gonna put the blood on like a little card. You guys ever did like a blood type test? That little card very similar to that. PKU should not be performed before 24 hours of age. Typically, they're gonna be done, I think it's like 48 hours in the hospitals when we typically do it. So again, we're doing a genetic screen to test for fetal ketonuria, galactosemia, and sickle cell anemia. You don't need to know what those all are, but it's congenital hypothyroidism. The galactosemia is a problem with the glucose storage, and then sickle cell anemia.
So we don't have to know what they are, but we should know what they're testing for,
Yeah.
correct? Okay.
A lot of times these tests are sent to state labs to have them run. So hearing screen, this is done prior to discharge. Can be done as early as 6 hours of age, but usually completed after 24 hours. Babies can have this repeated once, but if they fail it twice, they need a referral to audiology. At Frederick, at least, the people who do the hearing screen are contractors. So they're not hospital employees, it's a contract company that comes in and does the hearing screens. So what they do is they put like the EEG essentially on, they're gonna deliver sounds to the baby. Normally the baby has like headphones on and they'll deliver sounds, and they're just they're looking at brainwave changes in the baby when the noises are made. So CCHD, this is a congenital heart disorder or heart defect test that we do. Newborn screen for cardiac deficits using a pulse ox prior to hospital discharge. It's state mandated in Maryland. I'd say it's probably state mandated in most states again. Prior to screening, many seemingly healthy newborns went home and then had some sort of cardiac decompensation event and even died. So a pulse ox applied to the right hand. Why right hand?
For the heart, because it's opposite.
Postductal, yeah. And either foot at 24 hours of age. The infant passes if the pulse ox readings are greater than 95% in the right hand and within 3% in either foot. So, like 95 and 97, within that 3%. So if the initial reading is less than 90 in the right hand or either foot, it's an automatic referral to a cardiologist. May be repeated up to 2 times, but if the infant does not pass, they're referred for an echocardiogram. A lot of times these babies may get 4-point blood pressures also. So all extremity blood pressures. Almost 1% of newborns have some sort of congenital heart defect, and about 1/4 of those babies have a critical defect. This test, parents can refuse, but most don't because it's non-invasive and easy to do, and it can be potentially life-saving, right? Early detection is important in congenital heart defects, so that's what this test is for. Congenital heart defects are really the most common congenital defect that we see. Approximately 50% of congenital heart defects are missed in the prenatal period. Careful postnatal assessment is crucial for early detection. Clinical manifestations of CCHD can be a history of irritability, decreased activity, poor weight gain, feeding difficulties, cyanosis, tachypnea, increased work of breathing. Additional indicators could be enlarged liver, tachycardia, a heart murmur, weak femoral pulses. And again, Positive results warrant an echocardiogram and a follow-up with a cardiologist. So newborn care, bathing and hygiene. We typically hold off on doing a bath until a baby's 24 hours of age. We do the bath and the CCHD typically together at that 24-hour mark. We want to delay the bath as much as possible because we want that vernix to remain on the skin for at least the 6 hours, and baby has a little bit better control of thermoregulation the older they are. You always want to wear gloves in that first 24 hours when you're caring for a newborn, right? Because they still have all that bodily fluid from birth on their skin, so make sure you're wearing gloves. Clean water to their face and their eyes. You can use mild soap on the rest of their body. Doing a good job at cleaning their genitalia, doing an education to the parents on how to do diaper care and how to change diapers. For a female baby, we're wiping front to back. If we've been circumcised, doing circumcision care, which we have a whole slide on that, so I'll talk about that a little bit later. Making sure we're noting wet diapers and poopy diapers, how often, consistency. Sometimes we may even have to weigh diapers depending on whether or not we're concerned about baby gaining weight. Okay. Some babies automatically get a bath sooner than 24 hours. Those babies would be HIV, Hep B, or hepatitis C babies who've been exposed to moms with those conditions. Babies get sponge baths only, right? Because they can't be submerged until that umbilical cord has dried up and fallen off. So sponge baths for babies. Typically the umbilical cord falls off in like 1 to 2 weeks. Lots of teaching in regards to safety. Safe sleep, car seat safety, infection prevention, bonding, and prevention of abduction. What do we do in the hospital to prevent cases of abduction?
IDs, the tracker, the ankle monitor.
The ankle monitor, we put them on house arrest.
Mm-hmm.
So we've got our HUGS tag system, which is the security system. If the baby gets too close to a door, it's going to set off an alarm. We also have their ID bracelets. Remember, baby gets one on the arm, one on the leg, and mom and dad both get bracelets. Making sure that we're checking those bracelets before baby leaves the room, and then when we bring the baby back, we're rechecking those bracelets to ensure that they match. Infection prevention. What kind of items can we teach parents about infection prevention?
Hand hygiene.
Hand hygiene.
Bottles, like proper cleaning of the baby bottle.
Yeah, proper cleaning of baby bottles or pumping equipment.
Yeah, pumping equipment too. Yep.
What else?
Cradle cap.
Cradle cap. Okay, teaching on cradle cap. What else?
Oh, sickness.
How to cover your coughs and sneezes correctly, doing good hand hygiene afterwards. How about kissing your babies?
Ceramic.
I'm gonna kiss my own baby, but nobody else better be kissing my baby, right?
You should wait to take them out, like in public.
Yeah, limiting exposure to other people, right? Not taking them into necessarily crowded places right off the bat because baby doesn't have that immune system built up. What about safe sleep?
On the back, swaddled.
On the back and swaddled. Should I have a bunch of stuffed animals in the crib?
Nope.
Nope. How about pillows and blankets?
Nope.
Should I co-sleep with my baby?
Nope.
No.
Is it fear of co-sleeping that you'll like end up accidentally suffocating the baby?
Yeah.
Oh, okay.
Yeah.
Yeah.
And a lot of times our mattresses aren't firm, right? You want them to be on a firm, flat surface.
See, I was thinking because like most people sleep with blankets and pillows and stuff like that, but I was like,
Well, yeah, all of it. Mom or dad could roll over, baby could get tangled up in the sheets and suffocate, or suffocate in the blankets. Also holding the baby and falling asleep with the baby in your arms,
Oh, yeah.
head dropping,
Head support.
head support, yep.
I was gonna add on the like holding the baby in sleep. Shouldn't they not fall asleep in their car seat? Or like if they do in the ride home, that's okay, but move them immediately is what I heard.
Yeah, you
before.
should not let a baby sleep in their car seat. Like if they're asleep in the car seat, and the baby should only be in the car seat when the baby is in the car.
Right.
Like you shouldn't have them in the car seat outside of the car.
Right. Or like I don't want to wake them up. I'm just gonna let them sit here for a couple hours inside.
Yeah.
Like no.
Yeah, you should get them out because
Just
of
they're awkward.
this awkward position.
Oh,
Right.
Yeah, but they're sitting like that for hours in the car at times.
Yeah.
Coming from a mom.
I know
Yes.
that's it's not like a perfect
Yes.
rule thing, but
But whatever, yeah.
Yeah. But in the car, you're there in the car.
But you can't see them because they're
You
facing
can't
the other
necessarily
way,
see
like-
them, but you're more likely if you have them in the house to walk away from them, right, and not be close to them. Yeah.
That is-
Yeah. And then of course we have sudden unexpected infant death prevention. So ensuring, we educate about SIDS. We can follow the American Pediatric Safe Sleep recommendations, again, placing newborns on their back. Avoid co-sleeping, use a firm, flat mattress without soft items. You can also increase the prevention of SIDS by breastfeeding and avoiding smoke. Shaken baby syndrome, educating on that. That's when you've shaken the baby's brain hits the front of the skull, then hits the back, and we get subdural hematomas and bruising and bleeding, right?
I watched a thing on that though, where they had like I forget what they call it, but like pressure sensors to show like just how hard you have
it's
to
like
shake a
clear
baby to actually cause that. Like if you see somebody and they got shake a baby, that person was shaking the frick out of that baby.
Yeah. Yeah, you gotta shake them hard.
Yeah.
At what age is it safe to introduce blankets and toys and stuff in the crib? Like when they have more like motor control and stuff, or like toddlers? Like
I
Sensors?
honestly think it's like 2.
right, like till they're a little older and they can realize
Yeah.
like, oh hey, I'm suffocating, let me move this.
It's definitely like at 1, I don't even think you're supposed to introduce a pillow yet. I want to
Really?
say it's maybe 2. Not 100% sure. That would be a question for Dr. Breezy.
Can't some babies get shaken baby syndrome? Maybe accidentally like throw them up in the air or play
No.
with them.
No, I'm talking.
You
You
gotta
look,
like,
Google it.
you gotta
Google it.
shake
Yeah,
it.
watch that
It
video,
is-
they're aggressive, like
Yeah.
Because I've seen like TikToks of some.
No, those people shake their babies and kill them. They were lying. You do not get that.
So symptoms of shaken baby syndrome include vomiting, fussiness, and altered mental status. Again, the injury pattern is going to be that subdural hematoma, retinal hemorrhages, brain injuries, fractures. So risk factors here are young and unsupported parents, lack of prenatal care, behavioral issues, and lack of education, to be honest with you. So really educating parents on soothing techniques and dangers of shaking the baby. And when you're feeling overwhelmed and frustrated, it's okay to sit that baby down in the crib and walk away for a minute, right? That baby is gonna be safer in that crib than you being overwhelmed and panicked and feeling like you need to resort to that. So it's okay to put that baby down in the crib and let that baby cry and just walk away and take a couple of breaths, right? We talked about infection control, newborn abduction, bonding, encouraging bonding. What's a great time to encourage bonding?
Breastfeeding.
That golden hour, right? When that baby is most active. Umbilical cord care. So doing a lot of education on this because a lot of parents are like, what what do I do with this thing, this nasty thing that's hanging off my baby? They're kind of gross. I don't know if I told you guys or not. I like was in a jewelry box and I was like, what the hell is this? It was one of my kids' umbilical cords. I think it was Ella's. I don't know.
My
I'm
partner
sure.
saved ours.
Yeah, I don't know. I don't think I saved it. I think I ended up throwing it away. I'm like, why do I need this? It's like the baby teeth. I don't know what I'm doing with these baby teeth that Jack keeps losing. He's gonna find them soon and be like, the tooth fairy didn't take my teeth. Why do you still have them? That's what I'm waiting for. So anyways, with the umbilical cord, you know, we put the cord clamp on, we cut the cord. That clamp typically comes off at about 24 to 48 hours of life. Once the cord is nice and dried up, that clamp will come off. Sometimes they'll just cut the clamp off right prior to discharge even. Again, babies that still have the cord stump should not be submerged in water. You should be doing sponge baths. You never want to just like rip off the stump. You want to be careful with diapers. A lot of times you want to fold the diapers down underneath the stump. They even make diapers now that have like the little indent to go around the umbilical cord. So like newborn size diapers will kind of go down in the front just a little bit. Sometimes the cords do get snagged on stuff and they just fall off. That's okay as long as they're not bleeding excessively or anything like that, right? So doesn't warrant a phone call to the provider unless you notice something abnormal about it. But of course, monitoring for any redness, drainage, or foul odor. Circumcisions. So most important here for a circumcision, a baby needs to get a dose of vitamin K first, right? Again, baby's not born with the clotting factors that they need, so we need to ensure baby is safe to get the circumcision, and that would be with vitamin K. So the providers will refuse to do a circumcision if the parents have refused vitamin K. And if they do that, then that baby, and they still want the baby circumcised, the baby would be circumcised outpatiently a month or so later, 2 months later, depending on when the urologist, they actually have to go to like a pediatric urologist to have the circumcision done. Before we do a circumcision, we want to make sure the baby has voided, and they should be in PO for about an hour, right? So that baby's gonna get upset, they're gonna be laying on their back, they could, you know, spit up, all that kind of stuff. So in PO for about 1 hour. We treat it as a surgical procedure, so they need a consent signed by the parents, and we're gonna do that ID check before that baby leaves that room. So why do we do circumcisions? And what exactly is it? Well, it's a surgical removal of the foreskin, and it can be for cultural, religious, or health reasons, like just hygiene purposes, right? Because they have found that circumcision can reduce the risk of UTIs in males, yeast infection, HIV, HPV, and some penile cancers. So post-circumcision, I want to note the first void, and I want to educate on the care of the circumcision patient. So it's okay to clean it with soap and water, rinse, pat dry for diaper changes, but most importantly, I want to use petroleum jelly to prevent any sticking to the diaper, right? Fasten the diaper loosely, avoid placing on the abdomen, so meaning kind of folding the penis up and placing it onto the abdomen under the diaper so it's directed upwards instead of down. Report any bleeding or purulent drainage, redness, or swelling or fever, right? Do the babies get put under for a circumcision?
Nope.
What do they get?
Lidocaine.
Nerve block.
A nerve block.
Lidocaine.
Isn't that what they do? They shoot a little. I thought that's what he said he was doing.
Oh, yeah. They can get a little nerve block, I guess. But most of the time they're getting the sweeties first, right, to kind of get them into that euphoric state. So just sugar water, get them kind of euphoric, and then a little bit of lidocaine.
Is that topical or injection?
Injection.
Okay.
Yeah.
Oh, maybe that's what I'm thinking of.
Yeah, injection.
Is this another perk of circumcision? Like it would prevent phimosis or like paraphimosis? Like learning that from the peds lecture because it happens with uncircumcised boys. Right?
You're gonna have to tell me what Harry.
Right?
It's like where it's like
Mimosa.
stuff
Like
is
the
The band.
foreskin, like,
Gets caught
Oh,
in itself and it
yes.
cuts off circulation
Yes.
versus the other condition is like you just can't even pull back the foreskin to begin with.
Yes.
Like, so those two issues would be eliminated with circumcision.
Correct.
Yeah.
Yes. I'm like, you gotta tell me what that is. I've been an OB nurse for way too long. I don't know. All right. So newborn care and nutritional needs. Again, they need at least that 108 calories to grow or to gain weight. Fluid requirements for the baby is about 100 to 150 mLs a day, but is that of water or what is that?
no.
Of formula, right? Because the only thing that baby should have really in that first year of life is formula or breast milk. Feeding wise, breastfeeding or bottle feeding, whichever one you choose, but making sure that you're doing good education on both. Frequency, baby should eat about every 2 to 4 hours depending, right? The baby's gonna be sleeping every, for 2.5 to 4 hours straight. So you may at times have to wake the baby up to feed them, and that's okay. So if you have a baby who's super sleepy and doesn't want to wake up to eat, unswaddling them, kind of getting them naked, putting them skin to skin with you will help kind of wake them up so they will eat. What are some measures to decrease swallowing air, or if they do swallow air, because it's kind of inevitable, they're going to swallow air. So what do?
Give them the old.
Pacifying.
Burp them, right? Are you
Yep.
smacking them real hard on the back?
No, just
No.
got them like this.
Just a little tap on the back, right? Because it's not about the back pat. Burping isn't. It's actually about that sitting the baby up to release that air bubble. So sometimes all you have to do is transition that baby from laying to sitting up and they'll just automatically burp, right? So it's that moving of that air bubble. We want to ideally feed on demand as well. What kind of clues would tell us that a baby's hungry? Crying, rooting. What was it back here? I saw it. Restless, yep. Okay, good. So that irritability. So breastfeeding, we're gonna do newborn nutrition next week, so I'm not even really gonna talk about this. Most importantly here, remember the supply of milk is equal to the demand. The more sucking, the more milk. So if you want to increase the milk production, more sucking is necessary.
Would pumping do the same, or is it
Yeah.
specifically okay?
Yep, pumping. So the first period of reactivity for a baby is that first 30 minutes of life. So that's why we want to do that golden hour. Support the bonding, right? And it's one of the best times to establish breastfeeding, right? Because baby's alert, awake. We want to start early with the breastfeeding. Period of decreased responsiveness at 30 to 120 minutes old. So this is a period of decreased activity. Baby's going to be a little bit more lethargic. And then anywhere between 2 to 8 hours, they're going to wake back up and show interest and start kind of like interacting a little bit as much as a baby can, right? So that first 30 minutes to 2 hours, they'll be alert. Great time to promote bonding and breastfeeding. Babies need about 16 to 18 hours of sleep per day. Most of the time, their longest sleep should be about 4 hours. Most pediatricians will say at the 4-hour mark, wake your baby up. And then you have older people who say never wake a sleeping baby, you know, so it's one of those things. Babies have different stages of sleep. They have that quiet sleep, which is sleep with little movement, active sleep, which is gonna be that REM sleep, where the eye and the body is moving. Transitional sleep are periods between quiet and active sleep. A baby really doesn't develop a circadian rhythm until about 2 to 3 months of age. So they have no idea if it's day or night outside, right? So they're just sleeping when they're tired. They're not basing it off of day or night. So social interactions with a newborn. How can we know a newborn's trying to interact with us?
Responding, looking at you when you're talking.
Yep, responding, kind of looking at you when they're talking, making some facial expressions, right? Opening, closing their eyes, maybe reaching out. Not that they're necessarily reaching for you, but reaching in general. They can cry to communicate, right? Babies typically cry about 3 hours a day. So what are some methods that we can use to console a baby who's crying?
Rocking.
Pacifier.
Pacifier, swaddling, holding, walking. Did somebody say drinking?
I said mom.
I heard somebody say drinking. Yeah. Massage, right? But again, that inconsolable crying can potentially lead to that shaken baby syndrome. So teaching the parents good coping mechanisms, right? I was a big component of taking Jack on drives if he was crazy. Ella was never really too bad, but most of the time, if I couldn't get Jack to stop crying, we would go on a car ride. And it was COVID, so it was a different time of life anyways. There wasn't anything you could do but go for car rides. So we did a lot of car riding. So newborn care contains tons of preparation for discharge, right? As soon as that baby is delivered, we want to start educating on what mom and dad need to know for discharge. We always want to take into consideration cultural consideration. We want to ensure that they can get their follow-up scheduled. They have their pediatrician. They know when they need to see the pediatrician. We also want to teach them about warning signs and symptoms. What are some warning signs and symptoms for the newborn that I want to make sure my parents know?
Cyanosis.
Cyanosis,
Nasal flaring.
Poor feeding.
nasal flaring, poor feeding, sweating,
While eating, yeah.
lack of wet diapers is
Lack
a
of
huge one.
tears.
Lack of tears.
Lack of meconium for 48 hours.
Yeah, lack of bowel movement. Good. Fever in a newborn too can be really concerning. So those are all things I want to make sure that they can easily identify as reasons to call the pediatrician when they get home.
Bulging fontanelle.
Oh yeah.
Yeah, yeah. So newborn assessment, what do I need to know right off the bat? I need to know the prenatal history, right? So I need to know mom's GBS status, her hepatitis status, her HIV status, all of her labs, right? What type of blood type they are. I need to know how the baby was delivered, at what gestation was the baby delivered, right? Any complications during mom's pregnancy? Was she gestational diabetic? Was she a preeclamptic? What kind of medication was mom on, right? Because maybe she is a recovering drug user and she's been taking methadone. That baby could potentially go through withdrawals. So I need to know a detailed prenatal history of mom and intrapartum history, so complications during the labor and delivery portion, right? Any psychosocial issues? What's the family dynamic like? Is dad not involved? Is this baby going up for adoption? Is there a history of drug abuse? Any post-delivery findings. This is just a little chart for a newborn assessment. It looks terrible up here.
Oh, wow.
Newborn assessment vital signs. They're composed of heart rate, respiratory, and temp. We don't typically do blood pressures on babies unless it's been ordered by the provider for some reason, or they failed that CCHD. No rectal temps for temps. Typically we do axillary, but there are occasions where we have to do that rectal. So, for instance, that story I told about the baby whose temperature was so low, they couldn't get a temp, so she had no other choice but to do a rectal temp because we needed a temp. What's a normal heart rate?
110.
How long am I gonna listen for?
1 minute,
Good. What are normal respirations?
30 to
30 to 60. How long am I going to observe or listen for?
1 minute.
1 minute, right? So I should be observing the chest and abdominal movement and count those respirations for 1 minute, or I can be listening, whichever one is easier for me. Measurements. I'm gonna do a length and a weight. To do a length, the baby should be extended out, right? And I'm gonna measure from the top of the head to the bottom of the foot. The expected length range can be anywhere between 17 and 22 inches. Molding can affect this measurement. I had a baby that was like 22 and a half inches or something like that, but it was super cone head.
Oh.
So that baby is going to have some, changes in its length. It's definitely gonna get shorter, but that's normal, okay? Important to remember that babies lose 7 to 10% of birth weight by 3 to 4 days old. Anything more than 8% is concerning. Expect a regain by the 10th day. So they should be back to their delivered weight by the 10th day of life. Babies are going to be weighed immediately after birth, and then they're going to be weighed daily while they're in the hospital. Sometimes babies that have lost more than that 8% will have to go to the pediatrician outpatiently and have daily weights done. Head, chest, and abdominal circumference are also taken. We're going to measure at the widest point just above the eyebrows for the head. Anywhere between 32 and 38 centimeters. Can be affected by the shape of the head. Chest circumference is measured just below the nipple line, and head and chest circumference should be pretty much equal, okay? Then we have abdominal circumference, and it's gonna be similar to the chest and the head, but could be a little bit off. Like your chest and your head could be 13 and a half, and then your abdominal circumference may be 14. So they're all gonna be very similar numbers. So moving on to our assessment. So what does the baby look like? So initially that's really gonna be our skin assessment, right? So what do I see on the skin? How's the skin turgor? What's the skin temperature, the color, the integrity? Do I see any lanugo or acrocyanosis? I'm gonna make notes of any rashes, petechiae, or dark pigmented areas like cafe au latte spots or Mongolian
Bless you.
spots. I want to document the location, arrangement, type, and color. So all skin findings, even though they're normal, but they're considered abnormal. So anything that I see, I want to document on their skin. So we have vernix. That's that creamy white nasty stuff right after birth. Okay. Healing skin, very normal. Let's see if I can.
I think it's on your left. Isn't that?
There we go. Thank you. lanugo. That's that fine hair. This you can't see too well, but right back here we have like a red patch. This is the back of the baby's head. That's a stork bite. So it's kind of like a birthmark. They do typically go away, but not always. My husband has one in his hairline that I can see when he gets a fresh haircut. It's just like this red area.
Is it just in the back or can it be in the front?
It can be in the front too. A lot of babies will get it like in between their eyebrows too, or on their forehead, or on their eyelids. Little stork bites. So newborn head assessment. I'm gonna be looking for any cuts, scrapes, bruising. If the baby was a vacuum, they might have a big old vacuum mark on the top of their head. If the baby was a forceps delivery, they could have a mark from the forceps. I'm gonna be feeling the fontanelles and the sutures. What should the fontanelles feel like?
Soft and open.
Soft and open. I want to report sunken and bulging. The sutures are where those cranial bones meet, and I should report overriding sutures or separating sutures. Am I going to be concerned about overriding?
Yes. Oh, that's right. No, because when they're born.
Right. That head is going to kind of mold together, and those sutures may kind of start to override, and that's a normal, abnormal finding, right? I'm going to note any molding, caput, or cephalohematomas. So the infant's head molds to the pelvis during descent before and during the first and second stages of labor. The top of the infant's head is flattened, related to breech positioning. Okay, so this head here is flat, so that's breech molding. This is molding that the baby's head has molded to the pelvis during the first and second stage. Okay. Have you guys seen good molding yet? No. This baby here has the flat head from the breech molding.
We can't see your cursor, just so you know.
Oh. Thank you. I'm like moving my cursor all around.
Oh, there
You
it
guys are
goes.
like,
Now I can
what are
see
you
it.
talking about? Okay, here. This baby has the flat head from the breech molding. And it almost looks like the baby has low set ears,
Mm-hmm.
but it's not because they're aligned with the eyes. So that's something I'm going to be looking for.
Why do some babies wear the helmet to like form their head when they're older?
Because their heads are starting to flatten from having being in a laying down position or having their head up against something frequently. That's why it's so important to do tummy time with babies. Not put a baby to sleep on their belly, but actually doing tummy time with them so they can relieve that pressure off the back of their head. Again, so that flattening of the head would be breech. And then molding here. So this mom was probably like 9 centimeters for a long time, or even 10 centimeters for a long time. And that baby, head has kind of molded to the inside of that pelvis. Thank you for pointing out you couldn't see my cursor. Okay. So cephalohematomas, that would be this right here. This is just like a blood collection under the baby's scalp. So cephalohematomas, those babies are at a high risk for jaundice, as the neonate's immature liver may be overwhelmed by the need to break down the excessive red blood cells. This baby has bruising on its scalp, most likely could have been like a vacuum assisted delivery. Newborn assessment for the face. So I am looking for asymmetry, inability to close their eyes, swelling around the eyes, which is actually kind of normal, movement of the lip, any difficulty sucking. Babies are, they breathe from their abdomen, but they also breathe through their nose, right? So you can see some nasal flaring, but any significant nasal flaring is concerning. I'm gonna be assessing the mouth. I wanna make sure the palate is intact, and that they have a swallow and a suck reflex. I wanna note and report any natal teeth, report any white plaques that may be on their tongues, which are Epstein pearls. And those Epstein pearls will disappear in a few weeks. So, we have a baby up here on the top right with facial palsy. So this baby can't open the eye, it's gonna have difficulty sucking, so some sort of facial nerve damage here. Epstein pearls, you can kind of see here, there's like this white patch. Those will go away in a few weeks. This little baby has a tooth, little natal tooth. This is an older child, so don't pay attention to the teeth. Their teeth are not gonna look like that. That's an older child with a lip tie. So a labial frenulum.
Don't we all have that?
Depends on where it is.
Oh.
So yeah, you have a frenulum, but some, it's
closer.
down lower,
Oh, I see.
closer to the teeth, and that's gonna become a problem if you're breastfeeding, because baby's not gonna be able to latch quite as well.
I got worried.
Yeah.
I think I have that.
And then we have ankylosing, which is a tongue tie. Okay, so again, we all have that frenulum on our tongue, but this one doesn't allow your tongue to stick out very far.
Okay.
Then we have cleft palate. So this baby is missing a palate. We have cleft lip. So the lip isn't fully developed, and you can have cleft lip and palate. And when we talk about high risk newborn, we'll go into detail more about these. We can have baby acne or erythematoxicome. So this is just typical baby acne. Again, facial nerve palsy, milia. You can see kind of like little white spotted dots. Those are normal, they'll go away. Facial bruising. Can easily look at this baby and be like, oh my gosh, that baby's blue. It's cyanotic, I'm concerned. But it's just facial bruising. You can have a forceps mark and facial edema. Newborn assessment for eyes and ears. Eyelid edema, again, is pretty normal. We can also have subconjunctival hemorrhage related to pressure placed during the birth, so those popped blood vessels. Babies should be able to track objects to the midline. It is normal for the first 6 months for babies to have slight nystagmus. Low set ears or abnormally shaped ears, I want to make note of, because that can be associated with genetic abnormalities. And we want to make sure the newborn hearing screen is completed prior to discharge. So looking for ear tags. Sometimes babies will have extra little skin tags near their ears. Preauricular sinuses, so like ear dimples. You're gonna have low set ears, so this baby here, if you trace across, the eyes are not aligned with the ears. You have conjunctival hemorrhage, eyelid edema, and you can have congenital cataracts as well. Those babies will need some sort of eye surgery after birth. Neck and chest. So we want to assess for head control. We're gonna assess for any clavicle injuries. Clavicle injuries are, pretty normal with shoulder dystocias, vacuum birth, or large birth weights. And treatment is immobilization or pain management, but have you ever tried to immobilize a baby? It doesn't really work. Most of the time, they just go, not untreated, but just pain management wise.
Do they put them in the little, like, that thing?
No.
No.
Baby's chest is normally round, barrel shaped, and symmetrical. Babies can have engorged nipples with white discharge. Report supernumerary nipple, so an extra nipple.
Triple.
You're gonna hear fine crackles. This is gonna indicate fluid is still in the lungs, right? How can we get that fluid out? Crying, drying and stimulating, right? So I do want to report any diminished breath sounds, grunting, flaring, or retractions. And of course, if I hear any murmurs, I want to report those as well. This baby has a cystic hygroma, which is a benign fluid-filled sac, typically on the baby's neck, and it's due to a blockage of the lymphatic system. This baby here, you can see this kind of like sunken in area, has a clavicle fracture. So that's pretty typical. You can see like a sunken in area, but a lot of times you'll notice like a pallor or kind of discoloration on the opposite arm, or the arm that you're concerned about the clavicle fracture on. So I've seen them be like cyanotic or really white, but there's like a change in color with the clavicle fracture on the affected arm side. Intercostal and subcostal retractions, obviously we don't want to see. You can see subcostal retractions here. This baby's kind of protruding out the belly, and then it's sucked in at the ribs. These pictures aren't good up here. I would look at the PowerPoint on your computer to better see these pictures. So the abdomen should be soft and non-distended. Bowel sound should be active. The cord clamp should be in place for that first like 48 hours. You want to inspect the cord, make sure there's 3 vessels, right? 2 arteries, 1 vein.
No ligaments.
No ligaments. Assure the clamp is secure, and remove once it's dry. Okay. Babies have poor muscle tone and distension in their abdomens. A lot of times it's normal for them to have like an umbilical hernia, so because their abdominal wall hasn't completely formed, so you can see a little bulge at their umbilicus, which it can be normal. Again, you got your 2 vessel, this is a 2 vessel cord here. This is a dried up cord. Newborn assessment for genitalia. Remember, it's normal for female genitalia to appear engorged and edematous. It's also possible for babies to have pseudomenstruation, so like a false period. So they can have vaginal bleeding. It can be kind of like white and pink tinge, and that can be totally normal, again, from the increase in estrogen that they've received from the mom. Also want to report our meconian stools and make sure that we're passing urine and stool for both male and female babies. So that engorgement and redness. Newborn assessment of the extremities, checking for hip dysplasia. So we have Ortolini's and Barlow maneuver. For Ortolini's, you're going to be rotating inwards, and you could potentially hear a click or a pop. And Barlow's abduction, and again, click, pop. We have polydactyl, which would be an extra finger. You can see the extra finger hanging off to the side. Syndactyl, you've got webbed fingers or toes, clubbed feet.
Someone's looking for you.
You're gonna have a brachial plexus injury, which is a nerve damage, either an Erb's palsy or Klumpke's palsy. A lot of times this can be from a shoulder dystocia, so nerve injury during a shoulder dystocia. Newborn assessments, you also want to do the back and the spine. You want to check for dimple, a sacral dimple. Lots of babies are born with sacral dimples, but they shouldn't be too deep. And if they are super deep, you may need to get an ultrasound to verify closure. We actually had a baby this week that had probably the deepest sacral dimple that I've ever seen. I was actually really surprised by it. And tufts of hair. So having like a big area of hair right there can be a risk factor of some sort of spina bifida or neurotube deficit. Maybe some, when the spinal cord was fusing in utero, it didn't close all the way. So, that's it. Make sure you look at the newborn assessment reflexes and look at the pictures. It's a supplemental handout on Blackboard. Again, your test information should be available tomorrow.